I have the great pleasure to introduce our speaker, Dr. Allen, today. Dr. Chris Allen is a respirologist at the Firestone Institute for Respiratory Health and an associate clinical professor of medicine at McMaster University. His medical training was at Oxford University and the Royal London Hospital in England. He completed training in respiratory medicine at McMaster in 1984 and joined the staff of the Firestone Clinic. He is a member of the advisory committees for the Primary Care Asthma Program, co-chair of the Lung Health Foundation Provider Education Program. Dr. Allen's research interests have been respiratory disorders related to gastroesophageal reflux, and he also has a long-standing interest in pulmonary physiology, clinical exercise testing, program evaluation, and medical database development. I now hand it over to Dr. Allen. Thank you, Dr. Allen.
Well, thank you, Diane, for that kind introduction, and thank you to the Foundation for inviting me to kick off this series on COPD. So what we're going to do today, I hope, is show you the risk factors, the development of COPD, and I'm going to show you the importance of early life in prevention of COPD, the importance of spirometry, the impact of symptoms on the patients, the comorbidities that are so important in these patients and have a major impact on both the course of the illness and on mortality, and also say something about exacerbations and how they impact the trajectory of COPD. So first of all, the definition. So COPD is a common and treatable disease characterized by, I'm just not seeing on my screen. I guess I have to, okay, that's better. It's common, preventable, and treatable disease characterized by persistent respiratory symptoms and airflow limitation. So symptoms, airflow limitation, that's due to airway or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases, but as I'll show you, there are maybe other factors as well. So the global burden of COPD. More than 3 million people died in 2012 at 6% of all deaths. Now top 3 among the causes of death worldwide. And people with COPD typically are disabled by their symptoms, may have to quit their jobs early and suffer premature death. And globally, the burden is projected to increase in the coming decades because of continued exposure to the risk factors and the aging of the population. In Canada, we see a similar picture. And in Ontario, more than 1 in 10 people have COPD. It's the second most common reason for hospitalization after childbirth. I don't mean they're hospitalized after they give birth. And 45% of people with COPD only have spirometry testing to confirm the COPD diagnosis. And that's a major issue I'm going to come to later. So when we assess somebody for COPD, we need to assess them for risk factors. We need to confirm the diagnosis objectively, and that means spirometry. Radiologists will often comment on hyperinflation or query COPD, but more often than not, if we do spirometry on those patients, it may be normal. So you cannot diagnose COPD from an X-ray, but it's a critical investigation when we're evaluating symptoms, complications, non-resolving pneumonia, hemoptysis, and so on and so on. Objective evaluation of the symptom burden is important, and I'll talk to that in a little while. One needs to assess the severity of the disease, and one wants to prevent premature mortality. Comorbidity assessment is very important. And then there needs to be a careful assessment of the exacerbation history. So what about the host risk factors? Well, genetic abnormalities, and perhaps the most familiar one is alpha-1 antitrypsin deficiency, which results in excessive destruction of the elastic support tissue in the lungs, leading to airway collapse and emphysema. Childhood respiratory infections, particularly viral infections, and childhood respiratory illnesses are major risk factors. Early life factors, so if the mother is smoking, premature babies will more often than not have hyperreactive airways and lung damage. Aging, as part of aging, there is a loss of the elastic supports of the airways, so there will tend to be an increase in airflow with aging. Also, that in the past, COPD, lung cancer, and so on were considered to be predominantly male diseases. Now, it's at least equally prevalent in men and women, and indeed in lung cancer, probably now more women than men. And then underlying asthma and airway hyperreactivity. But underpinning all of this is socioeconomic status, because people who have socioeconomic challenges will often have poor living conditions, overcrowding, maybe higher prevalence of smoking, and many disadvantages that will predispose them to poor outcomes with COPD. Now, on the right, you see a panel, and I'm going to actually expand it because this is a fascinating and very important message that's come through in recent years. This is data from a number of population cohorts, predominantly in Europe. And these are when people are followed over basically a lifespan with regard to their lung function and symptoms. And what we see is, in fact, there are 4 trajectories. The green line at the top are the normal, healthy individuals. And what you see is that the lung function peaks in the early 20s, and then there is a gradual decline, loss of FEV1, maybe 30 mils a year. In contrast, if you look at the red line, the second line, these are individuals who start with normal lung function in the early 20s, but show an accelerated decline in FEV1. And these are the smokers who show rapid progression and end up in their maybe 40s and 50s with an FEV1 of maybe 50%. And this leads on to the complications of COPD. So that's sort of familiar, the traditional Fletcher model. Now, and what's been recognized, though, are these individuals who enter adult life with impaired lung function. And you can see that the FEV1 is 75%. So they're starting off with small lungs. There are those who may remain relatively stable. That's the yellow line. But there are those individuals, and that is the blue line at the bottom, who show what might otherwise be the normal loss of lung function. So compare the green line to the blue line at the bottom, but they end up with COPD as well. And the important thing is, in these individuals, they're not smokers. They haven't worked in dusty, dirty places. And overall, as you can see, that of this population, I think it's 11.6% developed COPD. If you look at on the right of the slide, half of those were the people who showed the accelerated decline from normal function. And the other half were those who entered adult life with impaired lung function. And this really emphasizes the importance of respiratory health throughout life and the importance of improving respiratory health in childhood. So environmental risk factors, smoking, not only cigarettes, but the various other things, cigars, water pipes, maybe e-cigarettes, and of course now cannabis. The smokers, when compared to non-smokers, have a higher prevalence of respiratory symptoms and abnormal spirometry. I mean, we know that they have a greater annual rate of decline in spirometry. That would be the red line that I showed in the previous slide, and they have higher mortality. As you know, smoking cessation can be effective with long-term quit success with the appropriate interventions, and perhaps success rates up to 25% can be achieved. And smoking cessation is the single most effective way to prevent and slow down the progression of COPD. Now, environmental risk factors. We've got smoking. Now, environmental factors, indoor air pollution. This is a significant problem in the northern communities. During the winter months, they're crowded into small houses with poor ventilation, and and they also the heating systems. So indoor air pollution, occupational exposure. Occupational asthma is the commonest occupational lung disease in Ontario. So a variety of occupational exposures. Outdoor air pollution, and again, in the north, forest fires, major source of pollution. The dust from the unpaved roads, together with, we're familiar with the smogs and the sulfur dioxide and so on. During the summer months, we often hear about the air quality index, and this shows that the index that the government uses, and what you see, and in the high and very high risk levels, certainly anybody with lung disease should stay inside. Now, objective measurements, and I'm going to say quite a bit about spirometry because it's so pivotal. So population surveys in Canada have estimated if you take a spirometer out into the community or into family practices, it's estimated that 70% of COPD has not been diagnosed, or if it is diagnosed, it's not diagnosed until the disease is well advanced. And you cannot diagnose COPD without spirometry. Without spirometry, symptoms, there may be overdiagnosis, unnecessary medications, or you may underestimate disease severity and lose the opportunity to intervene and prevent progression. It leads to suboptimal pharmacotherapy and increased hospital admissions, mortality, and healthcare utilization. So, spirometry. The three key parameters we talk about: the forced vital capacity, which is the volume of air exhaled by a maximum inspiration followed by a maximum expiration. The volume of air that is expelled in the first second is the FEV1. And then we look at the ratio of the FEV1 to the vital capacity. On the right, you see two spirometry traces. Trace A is a normal individual. And what you can see is there is the rapid exhalation, so the increase in volume. Time is on the x-axis, volume is on the y-axis, reaching a plateau in about 3 seconds, representing the forced vital capacity. And then you see that about 80% of the vital capacity is exhaled in the first second. That's the FEV1, giving you an FEV1 VC ratio of 0.8 or 80%. We prefer to express it as a ratio, then you don't get confused with percents are predicted. On the right, that's panel B. You see that this is an individual, first of all, who has a reduced vital capacity, probably due to airway collapse and gas trapping. But also, and the most striking abnormality is that it takes at least more than 6 seconds to begin to reach a plateau. So it takes, the air is coming out more slowly. That is, we have airflow obstruction, and that is reflected in the curve, in the slope. You can see that it is much shallower than in panel A. And if you look in the first second, because of the airflow obstruction, only 50% of the vital capacity is coming out in the first second in this individual. And the ratio of the FEV1 to the forced vital capacity is 56%. So that is airflow limitation. So also, individuals are of different sizes and weights. So we have to determine what will be a normal value for an individual. And this is based on age, height, and gender. And with a normal range, this shows the familiar bell curve defined by the mean and then the standard deviation. Now, the normal range for most tests that we do, and this is for spirometry, is the normal range is that in which there is confidence for inclusion of 95% of the normal population. In spirometry, we're concerned with the lower limit of normal, so we set that as a one-tailed test, the 5% level. So in other words, 95% of the population will be to the right of the lower limit of normal. And then you'll hear the term Z-score, which is the number of standard deviations the measured value deviates from the predicted value. The lower limit of normal for the one-tailed test that we use for spirometry corresponds to, I think, 1.65 standard deviations, or a Z-score of 1.65. So to give you an example, our patient is a 45-year-old woman with a history of cigarette smoking for 20 years. She's got a bit of a cough, some sputum. You want to know, does she have COPD? So here we have the forced vital capacity in liters, the FEV1 in liters, and the ratio FEV1 to forced vital capacity. The predicted value for this woman, you can see, is in the first column. Our patient has a forced vital capacity of 4 liters, which is above the lower limit of normal. The FEV1 is 2.4, which is below the lower limit of normal. So, and then the FEV1 VC ratio is similarly below the lower limit of normal. So just putting it on the bell curve, you can see the mean for the FEV1 VC ratio is 0.81. And our patient has an FEV1 VC ratio of 0.6, which is well below the lower limit of normal, with a Z-score of negative 3.56. So this would confirm the presence of airflow obstruction. Looking at the FEV1, is it normal or abnormal? So again, putting the number on the bell curve, the patient had an FEV1 of 2.4, below the lower limit of normal, and was negative 2.4 standard deviations below the mean, which is a Z-score of 2.42, which is 71% of predicted. So in this individual, there was a reduced FEV1 VC ratio. The FEV1 was below the lower limit of normal, 71% predicted, and the FVC was normal. Now, we have these arbitrary criteria for documenting the severity of the airflow obstruction based on the FEV1. And in this individual, it was moderate airflow limitation with an FEV1 less than 80% and greater than 50%. Now, if you have a very low FEV1, you should check the saturation of PCO2 if the FEV1 is below 35%, because that person will be at risk of respiratory failure. So you do your spirometry, and then you're looking for reversibility. If you make repeated measurements of the FEV1, the vital capacity, the variability is about 180 mils. So for a change to be significant, it should be more than 200 mils post bronchodilator. you can express that response in absolute terms or as an increase, typically of greater than 12%. But be very careful, because if the FEV1 is very low, a small change might appear to be, say, a 15 or 20% change, but it's not a significant increase. If the FEV1 rises into the normal range, this would be considered the patient would consider fully reversible and may suggest asthma. If the FEV1 does not rise to within the normal range, spirometry is consistent with COPD. So going back to our patient example, she had a reduced FEV1 VC ratio of 0.6. The FEV1 was below the lower limit of normal at 2.4 compared to a lower limit normal of 2.72 or 71% predicted. And there was no significant change in FEV1 after the bronchodilator. It was a 100 mil increase, which is not statistically significant. And it was only a 4% change. So this lady met criteria for moderate airflow obstruction consistent with a diagnosis of COPD. So much for spirometry, and I spent quite a lot of time on that because it's such a pivotal measurement in COPD. Symptom assessment is really important, and there are two useful, well-validated tools. The CAT test, the CAT test, is available online. You can download the questionnaires from the website at the bottom, CATES online, CATS online. It's well validated. It's 8 questionnaires, and you can see it has cough, sputum, chest tightness, dyspnea, quality of life, and so on. So it's 8 questions, score up to 5, maximum of 40. And if it's less than 10, it's low impact, 10 to 20 medium impact, 21 to 30 high impact, and greater than 30 would be very high impact. So a normal score, less than 5, a decrease in score of 2 or more over 2 months may signify improvement related to a therapeutic interventional rehabilitation, an increase in 5 or more in a moderate to severe exacerbation, and a stable patient will be a change of 1 or less than 1 over the course of a year, and an increase may identify a patient with rapid decline. So it's a really useful thing to incorporate in your regular review of somebody with COPD, and the patient can do it in a few minutes in the waiting room. The other useful measure is the MRC dyspnea scale. You're probably familiar with the New York scale for cardiac failure. And this, again, is simple. The patient can do it in the waiting room. And as you can see, for example, grade 3, I stop for breath after walking 100 meters or after a few minutes on the level. So here's a case example, and Gloria is going to start the poll. So Irene has to stop every block when walking her dog. Her social activities have decreased as she is often too tired and too short of breath. Her family wants her to consider having someone to come in and clean as she's getting too short of breath to do it herself. So could you please tell me what grade would you give her dyspnea? Okay, how are we doing? Very good. Can't go back. There we go. Okay. So the answer was 3. I'm sorry, that didn't come up. So the Canadian Lung Health Test is something else that you can do in the office, and identifies cough, sputum, dyspnea, wheeze. Do you get frequent colds that last longer? These people should have spirometry. So that's another screen that you can do in the office. Now, this is something that's useful because people frequently are overly negative about the prognosis. Once somebody has COPD, they feel, oh, it's the end, it's hopeless. We certainly see this when people get hospitalized. So this is a simple score that you potentially can do in the office. You do the MRC dyspnea score, you get spirometry, and then you incorporate the age. So this is the age dyspnea obstruction index. And and you can determine the estimated 3-year mortality. And this is well validated. So the points are assigned based on those 3 parameters. And here's an example. A 65-year-old has an ADO score of 4. So if you look at the fourth row, you can see 4 will correspond to 60 to 69. The MRC dyspnea score was 3, which gives you an ADO of 2. Actually, yep. And the FEV1 is 40% with an ADO score of 3. So the total score was 9 with a 3-year mortality of 20.1%. So that gives you a sort of a reference point and can be useful. And so you can say to somebody, yeah, this is a problem, but you'll be at your daughter's wedding in a couple of years if you quit smoking. So comorbidities is really important. And this is where you requires your clinical experience and skills, a proper examination and assessment. You're looking for cardiac comorbidities. Remember, these people have an increased incidence of malignancy, lung cancer, but also breast cancer is common in these individuals, diabetes, osteoporosis, reflux, and associated psychosocial problems. Now, the important thing, though, is to identify the comorbidities that contribute to mortality. And 40% of the deaths in these people will be due to complications of COPD, but 21% from cancer. So that's the importance of being on your guard. There's nothing worse than somebody missing a lung cancer. And for people at high risk, asbestos exposure and so on, there are programs of actually low-dose CT monitoring. And then 27% will be cardiovascular disease. So it's important to look for comorbidities because they impact on patient quality of life, but also identify those that actually can be critical. Now, why is it called the vital capacity? Well, the term was coined by Jonathan Hutchinson, I think it was in 1856, who actually the first person who developed spirometry and did a fantastic assessment of spirometry in a range of people, dwarfs, giants, sedentary workers, shipyard workers, and so on and so on. And so he identified that the lung capacity, the vital capacity, was just that. It predicted somebody's likelihood of survival. And we now know that vital capacity independently predicts mortality. All causes COPD, heart disease, lung cancer, and respiratory failure. It also independently predicts non-fatal events. It's associated with myocardial infarction, atrial fibrillation, diabetes. You can see the rest of it: stroke, pneumonia, osteoporosis, and would you believe it, facial wrinkling. And the seminal Framingham study that everybody is familiar with incorporated spirometry from the beginning. And I think that I like this quote: "This simple office procedure is a useful predictor of pulmonary disease and cardiac failure, and can effectively select groups of persons destined for premature death. Since the forced vital capacity predicts cardiovascular as well as non-cardiovascular mortality, this pulmonary function measurement seems truly a measure of living capacity. So I'm of course prejudiced, but I think that most cardiac patients, particularly those with heart failure, should have spirometry. And I would, okay, exacerbations. An exacerbation is acute worsening of respiratory symptoms resulting in additional therapy. It's a sort of, this is a definition that's used in the trials. Hospitalization for a COPD exacerbation is associated with a poor prognosis and increased mortality. And this quote is from the Canadian guidelines. Exacerbations are to COPD what myocardial infarctions are to coronary artery disease. They are acute, trajectory changing, and often deadly manifestations of a chronic disease. And the mortality related to an exacerbation of COPD is similar to that of a myocardial infarction. So classification, and this is really an operational classification. And this again is what's used in the various trials. It can be infectious, non-infectious, and of course can be what appears to be exacerbation of COPD could be an exacerbation of something else. And certainly we've seen everything, diabetic ketoacidosis, acute cholecystitis, peptic ulcers showing up and emerge as exacerbations of COPD because it's an acute illness in somebody who happens to have COPD. So this again, where your clinical skill and judgment comes in. A mild exacerbation is treated with just an escalation in short-acting bronchodilators. A moderate exacerbation requires treatment with the addition of antibiotics and steroids. Severe requires hospitalization or at least a visit to the emergency room. And it's the severe exacerbations that may be associated with respiratory failure. So you take the exacerbation history and patients are at increased risk if they have 2 or more exacerbations requiring antibiotics and corticosteroids in the previous 2 years, or 1 severe exacerbation requiring hospitalization. The FEV1 by itself is a poor predictor. And the best predictor of a frequent exacerbator is a history of previous exacerbations. So again, when you're seeing somebody after they've, presenting after an exacerbation, it's important to do a full debrief. What was the cause? And also identify whether contributing comorbidities. Was it, atrial fibrillation together with worsening airflow, for example? And this is the assessment tool. This is just summarizing from the current GOLD, which is the Global Initiative for Chronic Obstructive Pulmonary Disease, the GOLD tool. And the steps are: you confirm the diagnosis with spirometry, you assess the severity of the airflow obstruction, and then you do a risk assessment that's actually based on symptoms and exacerbation history. So you stratify the individual based on whether they have a high symptom burden or a low symptom burden. A high symptom burden would be for example, in the B quadrant, which is an MRC greater than or equal to 2, a CAT greater than 10. So you assess the symptom burden and the exacerbation history. So more than 2 exacerbations or 1 leading to hospitalization will put them in the high risk category, which would be group E, and then either A or B based on the symptom burden in an individual who is not a high risk exacerbator. And as you'll learn in the next talk, we use this schema to direct optimal pharmacotherapy. Hospitalization rates for COPD across Canada are increasing, and we need strategies to prevent this to prevent exacerbations. And again, we can do that with effective interventions that you're going to learn about in the next talk. Hospitalization is an indicator of poor outcome. This is a population survey. You can see from 21,000, nearly 21,000 participants in the US. I think they must have been veterans because 80% of them had smoked. And you can see that 27% of these had COPD. 18% of COPD patients had at least one COPD admission. And then when you look at the graph on the right, you can see that 50% of patients admitted with COPD, that's the dotted line, died over the following 5 years. So hospitalization is a critical event in the course of COPD. Now, frequency of exacerbations. This is a cohort study of 300 men followed for 5 years. And as you can see on the right, you've got A, which is the non-exacerbators. Group B is the infrequent exacerbators, so less, and then group C is the frequent exacerbators, more than 3 exacerbations, you can see with a much poorer survival. So hospitalization, frequent exacerbations, more than 2 a year. So how do you prevent exacerbations? Again, you're going to learn more about this in the next talk, but optimizing bronchodilator therapy, and the guidelines will direct you. Smoking cessation, vaccinations, obviously influenza, sorry about that typo, it's not influenza, it's influenza, pneumococcal, and of course now COVID. Having a self-management plan, and the key with COPD is it needs to be not only a written action plan, but it requires ongoing follow-up. So education alone doesn't do it. Education is a critical part of the overall care plan. Optimal pharmacotherapy, promoting activity. Pulmonary rehab is particularly effective if you can get it within 4 weeks of exacerbation. And it is been shown in many studies to not only increase functional capacity, but quality of life, and may prevent exacerbations. Now, mobility is really important, maintaining mobility. And this was a study using a portable activity monitor. It's an accelerometer, it's basically an accelerometer that people wore, so objectively characterize their activity. And what you notice is that people who are active survived for the 4 years of the study. People who were sedentary had worsening survival, but the very inactive had a very poor survival. Now, obviously, we need to realize that some of those people were very inactive because of the severity of the disease. But for a given level of function, maintaining mobility is critical. So our goal is to prevent mortality, as well as quality of life. And what are the things that may reduce mortality with COPD? Well, there have been a couple of recent studies that have suggested that dual therapy may reduce mortality in people with a history of frequent or severe exacerbations, the at-risk group. However, and you'll be learning more about this in the next talk, but there are some caveats here. And I'm not going to go into them now, but the other things, smoking cessation, I've talked about, pulmonary rehabilitation, I've mentioned. For people in respiratory failure, long-term oxygen therapy is certainly effective. For people with acute exacerbations and elevated PCO2, non-invasive ventilation, and then in selected people, lung volume reduction surgery. But the major things that one can do for these people is optimize pharmacotherapy, get them to quit smoking, and improve activity. I remember one practice group actually set up a lunchtime walking group because they figured the only way to get people to walk was to take them for a walk. And there was a study from Catalonia in Spain that looked at all the various factors that could improve mobility. And they looked at location, parks, and all the other things. And the two things that predicted activity and outcome were caring for grandchildren and looking and having a dog. Well, we can't prescribe a dog, but we can certainly prescribe exercise. So now I want to wrap up with a case study. Henry, a 62-year-old aircraft maintenance technician, so that makes you wonder what he was breathing, presents with worsening dyspnea for the last 6 months and has had a cold or two that lasted several months in the last couple of years. Increasingly difficult for him to exert himself, especially when walking on an inclined surface, so uphill. He's decreased his functional activities and is often tired and short of breath. Looking for comorbidities, there's no evidence of cardiac comorbidities, and he denied allergies. He's a smoker, he's diabetic, he's overweight, he's been cleared of cardiac disease. His x-ray shows hyperinflation. As I've said, that's misleading. He's on metformin and he's on ICS LABA inhaler with occasional short acting. Terminology: LABA, long-acting bronchodilator agonist. Beta receptor, long-acting beta receptor agonist. SABA, short-acting beta receptor agonist. So, can we have the poll, please? So, what would you do? Would you refer him, do spirometry, sputum culture, repeat the chest X-ray, or all of the above? So it's waiting for the answer. Do we have the poll, Gloria? Excellent. Spirometry would be the, you have to confirm the diagnosis. You're suspecting COPD. Now here is his spirometry. So just to remind you, the bell curve, and I want your attention to the standard deviation, 0, 1, 2, 3. On this graphic portrayal, you can see the predicted will be the mean, and the vertical lines are the standard deviations, and the lower limit of normal corresponding to 1.65 standard deviations. So Henry is a 62-year-old male, and you can see, and I'd like you to, first of all, look at the graphs at the bottom. On the left is the volume time plot. And you can see if the blue line is before bronchodilator, the red line is after bronchodilator. And you can see that even after 8 seconds, exhalation is still continuing. So he's got very slow exhalation. And you can see that after 1 second, you can see that the FEV1 is significantly lower than the vital capacity. You'll also note with the red line is what appears to be a significant improvement after bronchodilator. And on the right is the flow volume loop, which I haven't talked about today, but is what you're seeing is again that the increase in flow from the blue to the red. So looking at the numbers, so the FEV1 VC ratio is reduced at 0.42, below the lower limit of normal of 0.65. The FEV1 is reduced at 1.8 compared to a lower limit of normal of 2.54. And you can see that if you look at the graph, you can see it's 1, 2, 3 standard deviations, well below the lower limit of normal. After bronchodilator, there's a 280 mil increase in the FEV1, a 400 mil increase in the vital capacity, both significant, and the improvement in the FEV1 and vital capacity is 15%, consistent with reversibility. But note that the FEV1 after the bronchodilator is still below the lower limit of normal. So this is partially reversible airflow obstruction, consistent with a combination of both asthma. Oh, sorry, I've done it for you. He's got moderate. Sorry, I spoiled that. He's got a combination of airflow limitation, partially reversible, but not reversing fully to normal. So he's basically got COPD and asthma. Sorry, I blew that with the poll. So the key points, when you're assessing somebody's COPD, symptoms, risk factors, confirm the diagnosis with spirometry. Now, what about his symptom burden? Shortness of breath, trouble walking up the incline slope. He's got an MRC of 1. What about his ADO? So he's 62, which gives him a score of 4, MRC dyspnea score of 1, gives him an ADO of 1, 40% predicted on his FEV1, gives him a score of 3, total ADO score 8, 3-year mortality 14.5%. So he needs treatment, but you can be reasonably optimistic. He does not have significant mortality increase in comorbidity, and you know, you can do a lot to help him. Now, what about his exacerbation history? A cold or two in the lasting several months, that's abnormal. Last couple of years, it's a frequent exacerbator. And so what he has, he's goal 3, he's got severe airflow limitation, his exacerbation history, it shows him at increased risk. So he's going to need effective pharmacotherapy, at least with a combination of long-acting beta agonist and a long-acting muscarinic. And again, you're going to learn more about this in the next talk. So to wrap up, COPD is common, preventable, and treatable disease. 50% of heavy smokers develop COPD. Spirometry is essential for the diagnosis. Comorbidities are common, contribute to exacerbations, hospitalization, and mortality. Pharmacotherapy is based on the symptom burden. And optimal pharmacotherapy will improve quality of life, prevent exacerbations, reduce hospitalization, and may reduce mortality. And maintenance of physical activity is important. Okay. Thank you very much. I think we have time for questions now.
So anybody who would like to ask a question, please. Thank you very much, Dr. Allen. It was a wonderful, comprehensive talk. And I was busy trying to find all the links for some of the slides that you were referring to. So I couldn't find them all exactly. I hope that I did a good facsimile of what we were talking about. So anybody who would like to ask a question now, either you can unmute yourself and unmute or show your video if you would like to unmute and ask the question live, or if you would like to type a question in the chat, I will ask Dr. Allen for you. So Dr. Allen, it's not really a question, I guess, but it's a comment. You know, in all the years that I have been a respiratory therapist, I never really questioned why it's called vital capacity, but that makes perfect sense. I love it.
Yeah.
That's a new thing that I just learned after how many years of being an RT. I won't tell you how many years.
Yeah, spirometry is really underutilized. And I know that's a challenge that the Lung Foundation is engaged in, looking at ways that we can improve access for people who are interested, encouraging them to do their own spirometry. You can actually buy for, I think it's about, we used to be about $90, maybe $100. You can actually buy a peak flow meter at Shoppers Drug Mart that will also give you an FEV1. Now, I wouldn't recommend that be used for diagnosis, but for a quick screen, that's something like that. and then identifying who needs to have spirometry. But it does need to be done properly. And we need to creatively think of ways of improving the access, because it has so much to offer, both not only to respiratory patients, but to cardiac patients as well.
So Dr. Allen, are you referring to the thing, I think it's called a Pico 6? Is that what you're talking about?
It may be, I can't remember the exact name, but I think that yes, spirometry should be done well, but we need to be alert. Now, there's a very simple test that actually is being used in asthmatics, and that's the forced expiratory time. And you ask a person to take a maximum inspiration, put your stethoscope over the trachea, and with your watch, time the duration of audible expiration. And if it's more than 6 seconds, that would be suggestive of airflow limitation. Quick and easy thing that you can do in the office and maybe highlight people who need spirometry.
Would anybody like to ask a question?
Does anybody have comments on that? Sorry.
Okay, so there is one. Andrea has ventured to ask a question. So
Yes.
what she's asking is, I wonder if I have both asthma/COPD, as my FEV1 was declining and FEC increasing. When do I demos for patients when doing spirometry? I asked for spirometry and I was diagnosed with just asthma. However, 4 rounds of spirometry later and in Briolipta 100/25 micrograms, my FEC is 127%, 4.7 liters, and FEV1 is 97%, 3.04 liters. So FEV percent pre-dilation is 65%. So I wonder if I have both asthma and COPD.
That is airflow limitation, and that needs to be looked into. It sounds like you're on the right medications, and it's really interesting. I had a group of medical students and was showing them spirometry, and one of them, lo and behold, was astonished to find he had impaired spirometry, but it turned out that he was a preemie. So yeah, you will find it, but I think it's clearly something you need to follow up on with your physician.
You mentioned CHF and spirometry. Is there evidence that it should be done that I can bring back to my workplace?
Well, two things. People with CHF will often have risk factors not only for cardiac disease, but also for respiratory disease, same risk factors, smoking, for example. And if you've got somebody with congestive heart failure, if you did spirometry and found they had airflow limitation and you could improve their airflow, you might improve their dyspnea. Also, severe airflow limitation is an added will actually potentially impair lung function. I don't want to get into the mechanisms, they're quite complicated, but certainly that severe airflow obstruction exacerbates heart failure. So therefore, this is something you can potentially do to help symptom management in somebody with heart failure.
There's another comment here, and quite rightly so. Spirometry is sometimes done poorly. I would even venture to say not necessarily sometimes.
Yeah, I think spirometry does require some practice, and it's an art. And I think that some people become very expert at it. Some people will have access to a respiratory educator who's trained in spirometry. The PCAP program is an example of that. That certainly can help you with spirometry. And sometimes you're going to need to refer. And that's a real challenge because I know in many communities, that means referring to the hospital. And of course, with what hospitals have been going through, that's a challenge, getting it done. So there definitely is a need to improve the access to spirometry. And I know there are working groups working on that. But poor spirometry is worse than it can, is a real problem. I often joke that, in fact, if you go past our clinic lab and there's, with our spirometry stations are going, it sounds just like the L&D. It says, push, to encourage people to have a good expiration. So yeah, it is a simple test, but does require practice and quality control to do it well, which is why I think for most people, it's something that you'd want to refer out unless you've got the volume, experience, or enthusiasm to do it yourself. And the Lung Health Foundation does have some excellent programs in training people in spirometry.
Yes, I think Kristen posted a link to the professional section of the website that you can all access. Comment from Andrea: I wish we could review tricky spirometry cases with you after your second presentation. Josh says, any suggestions when having access to spirometry isn't an option, such as rural medicine, treating on speculation?
I think that is a real issue. Whether you can persuade, your local, I know Life Labs or whoever it is that does your ECGs and your blood work, whether you can persuade them to send some people off for training, and then there is some financial return on it. So it's definitely a problem, and it's definitely one that I know the Health Foundation is aware of and working on. And I think any advocacy or assistance in improving access to spirometry, because it is such a valuable tool. And the more you use it, the more you realize how valuable it is. And I think if you're having trouble getting it, maybe people at the Lung Health Foundation, or maybe the PCAP program can help you, because the PCAP program has respiratory educators all over the province.
Andrea says, I diagnosed mild COPD recently in a singer who still smokes 1 pack per day. So lung exercise is so important. She's in her late 60s and smokes more than 25 cigarettes per day.
Yeah. Okay. So she needs some help, doesn't she, with her smoking? Exercise, and of course, actually singing is very good therapy for COPD. On our rehab unit, we had one of the inpatients was actually a singer, and he brought his guitar in and led sing-songs and in the evenings. And this led to actually our local COPD support group actually setting up a choir. And singing teaches breath control and can be very helpful.
Yeah, I'm not sure how many people are actually on the call who are certified respiratory educators, but one of the components that's very stressed is in education is the behavior management and influencing behavior change. And so somebody who is still smoking, working on their motivation to quit smoking may be an ongoing challenge. And so, yeah, you meet the patients where they are and start from there to try to motivate them in other areas.
Yeah.
Andrea, you're fantastic. She's resistant to quitting, but is now contemplative. I'm still working on her. Andrea, give me a call, on the lung line, and we can talk. I'd love to talk to you. I love your comments. We are at time now. And I thank you, Dr. Allen, so much for this wonderful presentation. The accolades that are in the chat, are nonstop. And we look forward to the second session. So thank you very much. And thank you all for joining us today. Thank you for the sponsors, AstraZeneca.